Good afternoon. So I'm going to talk about managing some complications that are specific to the gastric bypass, and thank you to the moderators for inviting me to do this talk today. I have no disclosures. So the laparoscopic Roux-en-O gastric bypass has become exceedingly safe and efficacious. We know that the complication rate for a gastric bypass has been compared to those of a lap chole or a lap appy, and the mortality rate has been similar to a knee arthroplasty. But unfortunately, serious complications can and do still occur, and failure to rescue these patients can lead to significant morbidity and mortality. So I'm going to talk about 4 different complications that can happen after gastric bypass: small bowel obstructions, internal hernias, a Roux-en-O misconstruction, as well as intussusception. Some of these are exceedingly rare, and so it's even more important that we keep these high in our differential when we see patients after a gastric bypass. So first, with small bowel obstructions, really when you're evaluating someone for a small bowel obstruction, getting down to the etiology of the bowel obstruction will help you with your management. And making that diagnosis can be very challenging. It really requires that you have a high differential diagnosis in order to make the diagnosis quickly and instill your treatment. In this review of over 9,500 patients, a single institution cohort contributed their 620 gastric bypass patients and contributed 8,900 from the literature, finding an incidence of small bowel obstruction of 3.6%. When they really drove down what was the cause of these small bowel obstructions, what they found was that the overwhelming cause of small bowel obstruction after a gastric bypass was due to an internal hernia at 42% of all small bowel obstructions in the series. Adhesive disease and JJ stenosis was responsible for an additional 37%, whereas more rare causes of small bowel obstruction like port site hernia or intussusception or even hemobesors made up the minority of these patients. And when we look at what might cause you to have one type of small bowel obstruction versus another, you can look at different factors, and one of them is technique. So when we compared AntiColic versus RetroColic, we found a very different breakdown of what was causing these small bowel obstructions. And so a RetroColic gastric bypass is found to have a 5.1% rate of small bowel obstruction versus AntiColic at 1.7%. And the vast majority of these were attributed to internal hernias in the RetroColic cohort. JJ stenosis, as you can see here, was more responsible for in the AntiColic group versus the RetroColic. Further looking at technique, we look at how the JJ is constructed. And so I know we had a talk on how to construct the perfect JJ. And what we found, when we look specifically at small bowel obstructions, is that a hand-sewn jejunal had less incidence of a JJ stenosis versus a stapled JJ anastomosis. And unfortunately, this review did not go into further detail on how exactly it was stapled, whether a double or triple stapled technique was used. So other than technique, we can also look at, when the timing of this bowel obstruction is happening. If we see patients coming in early in their course with an early bowel obstruction, the most common cause is a JJ obstruction. This is within 30 days of surgery. The mean time to diagnosis in this patient group is 14 days. Patients coming in later than 30 days after surgery, the most common cause would be an internal hernia or adhesive disease, and the average mean time to presentation is around 21 months. When patients are presenting, you might look at how exactly they're feeling. What are they describing to you as their symptoms? Patients with a Roux limb obstruction may complain of nausea, fullness, or mid-epigastric pain that may be temporarily relieved by emesis. Patients with a BP limb obstruction may have that same nausea or fullness, but they may be more likely to have tachycardia or hiccups or shoulder or back pain. And common channel obstructions have a combination of these symptoms. So when we get our labs on these bowel obstruction patients, unfortunately, they're rarely helpful. You might see a lipase elevation in patients with a BP limb obstruction or a common channel obstruction, or elevated LFTs, but these are nonspecific. When we look at imaging, it's also relatively unreliable. This review looked at 105 consecutive patients who underwent imaging followed by operative exploration confirming a bowel obstruction. And in this series, they had a 4.4% rate of small bowel obstruction. And they looked at how reliable was CT, radiograph, or upper GI in diagnosing these small bowel obstructions. And what they found was that CT sensitivity of 51.1%, a radiograph sensitivity of 33.3%, and an upper GI sensitivity of 56.6%. And so what the authors conclude from this is that really imaging is unreliable, and that really it takes operative exploration for diagnosis and treatment when it comes to small bowel obstructions in this cohort. And they also really emphasize that it takes a surgeon and someone familiar with the bypass anatomy to review your imaging and make sure that you're agreeing with the call in full understanding of what's going on inside the patient's belly. So to talk a little bit about the small bowel obstruction management, I'm going to use this series by Karaki et al., who looked at over 1,700 patients who underwent a primary Roux-en-O gastric bypass. In this series, they were looking specifically at early small bowel obstructions. They had a rate of 1.7%. Their symptom onset was within 4 days post-op, and their symptoms here are in order of frequency, mostly nausea and vomiting. 58.6% of this cohort were diagnosed during the index hospital stay. The remaining were discharged to home and required a readmission. Workup of these patients included an upper GI in 72% of patients and a CT scan in 28%. When we look at the etiology in this group for early small bowel obstructions, it was consistent with what I mentioned earlier, that the majority of the obstructions were due to a narrowing at the jejunal-jejunostomy. 41% were attributed to elsewhere within the abdomen, such as within a trocar site hernia, an internal hernia, a twisted alimentary limb, mesenteric ischemia, or adhesions. And how these patients were managed. When the vast majority of these patients were managed operatively. The 20% that were managed non-operatively, 5 out of 6 of them resolved with conservative management. However, 1 did develop a gastrojejunostomy leak requiring drainage and an extended hospital stay. Of the 80% that were managed operatively, the majority had a laparoscopic converted to open procedure. 47% had their procedure completed laparoscopically. And what they had done in the operating room really depended on what the etiology of the obstruction was. And so in the majority of these, it included a JJ revision or a hernia repair. The mean time to diagnosis in this study was, from diagnosis to operating room, was 2.1 days, and 17% of patients required more than 1 operation due to ongoing signs of sepsis or need for additional bowel resections. What we found from this study is that really patients with an early small bowel obstruction after gastric bypass have an increased length of stay, and 82% of patients had an additional severe complication after this. And so we know that early small bowel obstruction is a rare complication of gastric bypass, but it's an important one to keep in mind because it can have substantial impact on patients' morbidity and mortality. It's important to remember in the first 30 days that an obstruction is most commonly related to the JJ, and whether or not that's technique related is debated. And quick diagnosis and treatment is recommended for optimal outcome. So moving on to internal hernias. Internal hernias have an estimated incidence between 1% and 4%. I mentioned that internal hernias and adhesive disease are the most common causes of late small bowel obstruction beyond 30 days after surgery. The presentation can be several different ways. You can have epigastric pain, have an acute presentation that's suggestive of a bowel obstruction, or you can have relapsing intermittent abdominal pain separated by periods of normalcy. When we're trying to make the diagnosis of an internal hernia, we really need a high index of suspicion. Labs are unhelpful unless infarction or necrosis is present, and imaging is unfortunately pretty low yield. This study that I have referenced here looked at 7 different CT findings, and when trying to find which would tell us definitively if someone had an internal hernia. And what they found is that the mesenteric swirl, which is what we commonly look for on CT imaging, had a sensitivity of 78% and a specificity of 89%. The other different CT findings that they looked at listed here had less than ideal sensitivity and specificity. And so really we come back to that the gold standard for diagnosis is operative evaluation. When we do make it into the operating room looking for an internal hernia in someone we're suspecting, there are several pearls of operative exploration. And the first is to reduce the hernia contents. And so doing so, you want to start running the bowel from the ileocecal valve and working your way proximally towards the ligament of Treitz in order to fully reduce the bowel. Assess all potential spaces for hernias. This includes Peterson's space, the JJ mesenteric defects, and if you have a RetroColic Roux limb, looking in the mesocolonic space as well. These defects should be closed with non-absorbable suture. Next, we're going to talk about, the dreaded Roux-en-O. So this is an exceedingly rare complication after gastric bypass. It's so rare that you can't really find an incidence for it. And what happens here is there's a misidentification of the Roux limb with anastomosis of the BP limb up to the gastric pouch. This has been reported to occur during the index operation or during complicated revisions. And the presentation that patients are coming in with really is chronic. Patients will come in with chronic nausea and vomiting, bilious emesis, and malnutrition. The diagnosis actually, in the literature, describes it as being quite hard diagnosis to make. And so it's, the reports that they have written about mention a bowel dilation that might be present, but it's really nonspecific. You may see decompressed bowel distal or a gasless abdomen. And what's really characteristic of it is a fluoro exam that's demonstrating abnormal retrograde motility on the fluoro exam. And so as you can imagine, your BP limb the motility is going to bring your duodenal succus up your alimentary limb into your gastric pouch, which causes your bilious emesis. Management is revision, right? So we need to reconfigure this into a Roux-en-Y reconfiguration. And patients, the reported patients in the literature do very well after this. Now on to intussusception. So intussusception is a rare complication after gastric bypass. The incidence is between 0.07 and 0.6%. The most common type of intussusception is a retrograde intussusception of the proximal common channel towards the jejuno-jejunostomy. And this is in 86% of patients. And what's interesting about that is that's not really the normal way that we have intussusception in adults. And so when intussusception in adults is generally related to a lead point, it's an antegrade intussusception. And so this is very different in this patient group. And there isn't a really clear description of why patients are having this happen. There's some theories that it may be an abnormal motility issue with the migrating motor complexes, and some people have theories that's regard to the JJ suture line acting as a lead point. Patients may present with symptoms like a small bowel obstruction, or they may have acute episodes or relapsing symptoms that sound more like an internal hernia. 10% of patients may have a palpable mass on their abdominal exam, and the average time to presentation is 36 months. Intussusception is definitely more common in women, and it's also more common in patients that have a high excess weight loss. There's some reports of patients that have upwards of 90% excess weight loss having intussusception. The workup, labs again are unhelpful. Imaging is a little bit disappointing. X-ray might show you an obstructive pattern, and a CT scan may have that classic target sign at 82% of the time, having sensitivity in around 80% as well. So the management of intussusception is still debated. So, people wonder if you can just reduce the intussusception, should you resect or should you revise the JJ? And what we do know is that the recurrence rate when you treat this with reduction, with or without plication or pexy, and compare that to patients who have a resection or a reconstruction of their JJ, there is a 33.3% recurrence rate versus 7.7% recurrence. So, the guidelines for providers really is you can consider the acuity of the presentation, how recurrent the symptoms are, and really take into consideration all of these factors when you're deciding how to treat someone for intussusception. Some people are very sure that it's a JJ lead point that's causing this and suggest some technical modifications at the JJ when it's in your creation, whether or not that's making the JJ caliber smaller or adding additional stitches like we talked about earlier. So, we know that the laparoscopic gastric bypass is safe and efficacious, but some complications do still occur. So it's important to recall, the complications that can happen, like the ones I mentioned in this talk. However, they're rare. They need to be high on your list in order to appropriately diagnose and treat them. And also just making sure that you're reviewing all of your own imaging studies and to allow for clinical correlation in patients that have a complex surgical abdomen. Thank you.